Okay. Next, Dr. Jyotish Khillar. Yes. The topic is surgical outcome of MMC augmented NPDS and phacoemulsification in eyes with end-stage glaucoma.
Thank you, judges. My topic of presentation is visual and surgical outcome of mitomycin C augmented combined non-penetrating deep sclerectomy and phacoemulsification in eyes with end-stage glaucoma. So NPDS is an ab externo filtering surgery. It enhances aqueous outflow by excising external trabecular tissue and inner wall of Schenck's canal. In advanced glaucoma with split fixation, trabeculectomy may pose a high risk of macular snuff out. NPDS being a non-penetrating surgery could be safer alternative in such eyes to avoid vision loss due to macular snuff out. Very few studies compared the both and none have recent data. So it's an approved retrospective observational study in a tertiary eye care hospital where 349 eyes of 324 patients were studied in between 2018 to 22. All surgeries were done by same team of experienced surgeons. Under inclusion, age more than 18 year, open angle of POAG, pseudoexfoliation glaucoma, primary angle closure glaucoma with superior open angle, severe glaucoma with significant cataract and HFA showing split fixations were included. Under exclusion, the eyes with standalone NPDS, poor visual acuity, not amenable to perform fields, unreliable visual field, intraop complication with NPDS deferred, and previous intraocular surgeries and any media opacities are excluded. In preoperative evaluation, BCVA, IOP, slit lamp examination of vertical cup disc ratio and gonioscopy and HFA 10-2 were recorded before surgery. In surgical method, after injection of mitomycin C, a superficial scleral flap of 5 into 4 mm rectangular with uniform depth were raised till clear cornea with deep 4 into 4 mm scleral flap cautiously, followed by dissection of trabecular descendant membrane and scleral tissue, deep scleral tissue resected. The end point is the seepage of aqueous humor, followed by closure of scleral and conjunctival flap, and finally the clear corneal temporal phacoemulsification. So in post-operative care, antibiotic and steroid drops have been given in tapered manner for 12 weeks, cycloplegic for 4 weeks, and post-operative maneuvers like laser goniopuncture and bed knitting for bleb survival has been done. In follow-up was done in day 1, 14 days, month 3, 4, 12, 18, and 24, in which BCVA, intraocular pressure, number of AGMs were recorded in every visit. Visual field in 3, 4, and 3, 6, and 12 months, intra-op and post-op complications and intervention and occurrence of wipeout phenomena were noted. So in results, this is the demography of study participants where POAG recorded the majority with 62.8%. Here you can see in visual acuity, there is significant improvement in visual acuity with stabilization in subsequent follow-up visit. Similarly, in visual field also there is stabilization compared to baseline. So our primary outcome measures based on visual field, which gives a success rate of 93%. So in terms of intraocular pressure and number of AGM, there is significant results in follow-up visit over a period of 2 years. It contributes in secondary criteria for success. In complication, we recorded highest with refractory raised IOP in 29 eyes. We have additional procedures like AGV, RD, and diode cyclophotocoagulation in 5 patients. So we observed a 93% success in 24 months based on visual field stability. There is significant improvement in visual acuity, reduction in intraocular pressure, reduction in need of AGM, minimal intra and post-op complication, and fewer intervention. Previous reports compared trabeculectomy with NPDS have lower risk post-operative vision-threatening complication like hypotony, maculopathy, choroidal detachment, shallow anterior chamber, etc. We recorded only 1 patient with choroidal detachment which spontaneously resolved without any intervention. Previous literature shows a risk of wipeout phenomenon in an invasive procedure in a range of 13.6%. We do not encounter any such phenomenon. Intraoperative use of MMC in NPDS was less reported earlier. We observed a significant IOP reduction and reduced need of AGM, which relate to the use of mitomycin C injection. The long-term survival of NPDS depends on maintaining the intrascleral space. In our study, we believe it's because of MMC. So eyes with advanced PSCG are generally at greater risk for any penetrating surgery, and with NPDS, this risk may be minimalized. So we have included a subset of high-risk PACG of around 51 eyes, where we observed no vision-threatening complications. So limitation, we missed ASOCT assessment of bleb morphology due to retrospective nature. No subgroup analysis has been done. And in strength, our study has a large sample size with long follow-up period of 24 months, exploring the efficacy of mitomycin C in NPDS. And inclusion, we have included PACG and pseudoexfoliation. So MMC augmented NPDS is combined with phacoemuls surgery is a safe and viable option in eyes with advanced glaucoma with post-operative stabilization in visual acuity and visual field. Thank you.
So next person we have is Dr.